Have you ever wondered what your lipid panel really says about your health? Well, whether you're an everyday athlete or a health-conscious individual, understanding your cholesterol levels is key to being healthy. In today's video, we're breaking down everything you need to know about your lipid panel. We'll look at each part of your lipid panel: total cholesterol, LDL, HDL, triglycerides, and more. Plus, we'll even talk about how things like diet, exercise, and insulin resistance can affect your results. So let's dive in. Let's start talking about our standard lipid panel. So if you go to your doctor's office and you get a lipid panel or your cholesterol panel, this is what you're going to get. I'm going to scroll down here real quick. I'm going to pull up a PDF. This, if anybody's watching here, you can see, but if you're not watching, you're just listening, you'll see a PDF essentially of a lab readout. So this is a pretty standard lipid profile. It's looking at things like total cholesterol, triglycerides, HDL cholesterol, LDL cholesterol, VLDL cholesterol, and they even have some ratios on here of the LDL to HDL and total cholesterol to HDL. This is a pretty standard one. They have reference ranges here, and they talk about the unit, which is milligrams per deciliter. That's what we're talking about there. And I'll explain why we measure that and why it is what it is. This is a pretty standard lipid panel. This is what you would see. And I just want to talk about a couple things here is that the total cholesterol is everything, right? And so just stepping back for 1 second, cholesterol on these lab readouts is measuring how much of this cholesterol is available in a deciliter of blood. So how much is actually there? So essentially, if you have a big amount of cholesterol, it is measuring that. It is not counting how many cholesterol carrying lipoproteins there are. So one more step back, you have these things called lipoproteins. These are proteins that carry the cholesterol. Cholesterol does not play well with blood in terms of does not dissolve in well with it and doesn't move well with it. So essentially we need a carrier protein to carry cholesterol through our body. So those are lipoproteins. On these lipoproteins have a certain amount of cholesterol. And the cholesterol tests are measuring the amount of cholesterol on those carriers, not the total number of carriers. And we'll talk why that's important in a second. But so that's why you're saying the units are milligrams per deciliter. That's why we're measuring the milligrams per deciliter of cholesterol. It's total cholesterol content, not these particles. I just want to clarify that. And specifically, LDL is actually a calculated number and not counted. And this is kind of, once again, counting the amount of cholesterol on the proteins, but it has other things into consideration as well. They're calculated using triglyceride levels, and that's why it's important to be done fasting so we can kind of minimize those and see where your natural triglyceride levels are. And so long story short, LDL is calculated specifically, and then we have HDL, which is just a, counting everything there, and total cholesterol, which is counting everything. It's kind of complicated, but at the end of the day, we're going to break down what all these look at, what all these mean in just 1 second. So moving on from our standard lipid panel, I just want to talk about total cholesterol. Like I mentioned, as you can see here, I have a lot of writing on there, and it's not to confuse you, but all it's saying here is total cholesterol is adding up all the stuff. So all the cholesterol in there, not triglycerides, but all the cholesterol. So things like HDL and LDL and VLDL, those all go into total cholesterol. And those make up the majority of your cholesterol. There are other things called, IDLs, which are essentially intermediate density lipoproteins. We have chylomicrons, LP(a), and you have remnants. All those things play a much smaller role, and the bigger ones that contribute to the total cholesterol are your HDL, LDL, VLDL. And you might be like, well, what does that even mean, HDL, LDL? I have a whole podcast series all about cholesterol if you want to go back and be a huge nerd and listen to that. But the 20,000 foot overview is that we talk about density, right? So very low density. So VLDL means that there's a whole lot of cholesterol on one single lipoprotein. And then that loses some of that cholesterol and shrinks down and becomes more dense and becomes a low density. So still not very dense, but not as, it's more dense now. And those lose more cholesterol, become IDLs, and lose more cholesterol, become HDL. So HDL is that high density where you have the least amount of cholesterol compared to the protein. That's just a way of saying that's how your body uses and utilizes cholesterol. It drops it off and it comes back and does all that stuff. But that's what HDL, LDL, VLDL, all those things actually mean. And LP(a), we've talked about this before. That's essentially a LDL cousin. It has an ApoA protein, extra little protein attached to it, and it's more atherogenic, meaning it's when you have a higher level, you have a high risk of cardiovascular disease. That's not what we're talking about here necessarily. Just understand that that does play a role as well. But the vast majority of stuff going into your total cholesterol is going to be your HDL, LDL, and VLDL if we're fasting, because a lot of times if we're not fasting, there are issues. And that's going to bring us right in here. I want to talk about these fasting considerations that when you have your total cholesterol, we have, once again, HDL, LDL, and VLDL predominantly. And that's when we're fasting because there aren't things called remnants or IDLs, which means we're kind of breaking things down. If your triglycerides are elevated, either around like 150 to 2, then there's usually a delay in the breaking down of these triglyceride-rich lipoproteins. So essentially your body's breaking down, it's taking slower. And so there's more hanging around, and that may elevate the total cholesterol more, but it may not accurately reflect the particle number. And as I mentioned before, particle number is how many of those lipoproteins or those ships carrying the cholesterol are there. And if you have a higher triglyceride, that may indicate that it's taking longer to break down those triglycerides. And if you have more cholesterol hanging around, it may falsely elevate your total cholesterol, but in reality, you may have a lower risk based off of the number of particles. So that's kind of the question in all these tests. We'll talk about that in the next slide here. But if you're not fasting, you may have a falsely elevated number. That's something to consider. And then moving on to the next point here is the LDL particle versus LDL-C. So as I mentioned before, we talked about concentration, which is the amount that's being carried on these boats, or the particles, which are the boats themselves. So as I mentioned before, LDL is a calculation or an estimate of the amount of cholesterol. It doesn't actually count the particle number. They can be discordant. Discordant meanings one's off versus compared to the other, and it may not estimate risk properly. So what may happen is if you have a low LDL, there could be tons of small particles, which is bad. So when you say, hey, your LDL is looking pretty low, but you have a ton of particles, that's actually a higher risk situation. Insulin resistant states commonly have very small LDL particles and lots of them, but their LDL-C may not be elevated. So that's one thing to think about, is that it may not accurately reflect your risk. That's one thing. Obviously, the inverse can happen as well, where you have a higher cholesterol but lower particles, and that's a lower risk. It's not that easy. It's not one-to-one all the time, but that's just understanding why we care so much about looking at the whole thing in the whole picture. And LDL particles are typically not really ordered a lot. You can get some advanced ones to definitely look at that, but we have a pretty good proxy that can serve for that. And I'm going to talk about that here next, which is the ApoB 100 or ApoB. Most people talk about ApoB. They've probably heard about it. If you're listening to this podcast, you're in that space. Most people have probably heard about ApoB. It is found typically on everything that is not HDL. So there's two different types of ApoB. There's ApoB 48, ApoB 100. Don't really care about that necessarily, but ApoB is on things that are not HDL. So specifically things like VLDL, IDL, LDL, and Lp(a) as well. And then you can find the ApoB 48 chylomicrons. What I'm saying is, why do I mention this? And you're like, well, that sounds like a lot of nerdy garbage. What does it matter? Well, it matters because this is a marker for each single particle, right? So each single lipoprotein, you have these ApoBs on there. And so specifically, it's going to look at the VLDL, IDL, LDL, and Lp(a), or the ones that we think are the atherogenic or cholesterol that contribute to cardiovascular disease. And it's probably our best tool, this ApoB, for correlating risk because it accounts for all of these atherogenic particles, but about 85% is LDL. And so that's why a lot of people will say, LDL, all that matters. In general, LDL does track with ApoB. In general, there are some exceptions to that, but this is a more granular view saying, hey, I can look at it a little more closely here and we can know exactly how many particles there are. So if you have just an LDL, we'll kind of walk through like a standard panel that just has LDL, doesn't have ApoB. We'll talk about how to evaluate that as well. But if you have ApoB, usually it's an add-on test for about 30-ish, 40-ish bucks, something like that, can give us some more information as well. Not necessarily all the time, but can be helpful for stratifying risk. And so another reason why we care about that is just because it can clarify the picture just a little bit. And so that's kind of what we're thinking about. And that's what we talk about ApoB. That's what we're talking about. And then kind of going in here, a little aside is, what determines which lipoproteins actually get in the endothelium. So the endothelium is the inner layer of your blood vessels. And that's what causes atherosclerosis. And we care about particles because the particle concentration seems to matter a lot. If it's less than 70 nanometers, it can get in there into the particle, but that also depends on the endothelial integrity as well. So what I mean integrity is if you do things like if you smoke, or if you have high blood pressure, or you're poorly controlled blood sugar, those can all disrupt the endothelial integrity, which means the ability of your blood vessels to keep things out. And if you damage those, then stuff can come in like these ApoB particles and start causing atherosclerosis. And so we care about particles because it also does seem to be driven by a gradient, right? If you have a really high gradient of something outside wanting to get in, it's pushing towards there. So if you have a ton of particles hanging out, there's a higher chance that just by diffusion, it's going to want to go into that artery wall. And that's why we care about particles as well. And if you look at a couple other things as well, the LDL diameter is typically about 18 to 23 nanometers. So even if it's a small LDL or a big LDL, it can get in, right? So we talked about anything less than 70, LDL is well within that. VLDL usually can fit in as well. It's enormous, but at the end of the day, small VLDL, LDL, and IDL remnants can all get into there. So that's why, once again, we care about particles, right? We look at all those particles because the more particles you have, the more chance there is for that to get inside your artery and start causing atherosclerosis. Obviously, it's a combination of having the endothelium damaged so that it can get in there. You have to have inflammation to kind of create all this going on. So there's a whole swell of things, but it's definitely a risk factor in cardiovascular disease. And that's why we care so much about particle number and why people are talking about it now is because, you may have a different situation where let's say your LDL is low, but you have lots of particles because you have insulin resistance or metabolic syndrome. That's a higher risk situation than what the result would typically show. So that's why we care about it. And so now I want to go on to how to read a lipid profile. So this is kind of the framework we walk through here just to generally think at it. So first things first, we tend to look at triglycerides just because that can tell us how much we need to change how we view this. At the end of the day, if you have triglycerides that are super high, like greater than 500, then we're going to need some sort of treatment to kind of get those down because that can lead to things like pancreatitis. And so first things first, there's that. And then obviously if it's less than 500, think about, where are we going? The goal ideally should be like less than 100, but less than 150 a lot of times is what labs say. And once again, we talked about that. If your triglycerides are elevated, then that may falsely elevate total cholesterol and other things like that. So just something to think about there. So after we look at triglycerides, we can move on to our LDL or ApoB or something like that. LDL, typically the recommendations are, and this is just I'm just walking through what the guidelines typically say. Obviously, I understand that interpreting lipid panel is much more nuanced and you're not just a number, but this is just kind of going through the general framework of what, modern medicine says and does. And obviously your discussion with your doctor will be very different and you kind of talk about all these things, but this is what the general recommendations are. Is if you have an LDL greater than 190, they pretty much say they recommend you to start a therapy. If less than 190, then we can kind of use other measures to kind of clarify things. Overall LDL goals are LDL goal of less than 100, less than 7 if you've had cardiovascular disease before. This is changing frequently as well. They're going lower and lower and lower by the day. They're starting to see that once you get LDL around 60 or 70, we start to see essentially either regression or stopping of atherosclerosis. So people who've had that aren't adding on any more atherosclerosis in their arteries. And so people are going lower and lower and lower. And I think it's just a matter of time until probably the goal for most people is less than 70. We'll see if we get there. That's challenging potentially in our Western society, but that's just the way it seems to be heading. In terms of ApoB goals, a recent article came out that was kind of cool. Talked about how we can kind of use LDL goals for ApoB as well. And so ApoB, if we use the same as LDL, it's just a little more accurate test. And then next we want to go over looking at HDL. HDL, if your HDL is less than 40 for a male or less than 50 for a female, this is kind of an area of concern. Some people talk about I have a very high HDL, I don't have to worry about things. That's not the case. HDL isn't a get out of jail free card, but it does seem to be related to kind of metabolic syndrome, and that if you have a lower HDL, typically we're not as metabolically healthy as we'd hope for. So we're trying to get above there. There may even be a U shape where if you're too low or way too high, that may be a problem. We're still working on that, trying to get that out. HDL is pretty confusing, but that's something to think about as well. So after you look at those first couple things, then we can calculate a total cholesterol to HDL ratio. And if that ratio is greater than 4, that does signal a concern. They tend to find a correlation with people who have a ratio higher than 4 with increased cardiovascular mortality. Then after that, we can calculate our non-HDL. So non-HDL is total cholesterol minus our HDL. And we mentioned this can be useful if triglycerides are in the 200 to 500 range. So if we're a little elevated, this might help us get a better understanding of the actual particle estimation. And then once we've calculated non-HDL, we can also add on 30. So essentially that's accounting for things like the LDL. So if the goals were, 70 or 100 for LDL, it'd be 100 and 130 roughly. That's very, very rough estimate, but that's what we're looking at. Then you can also calculate the triglyceride HDL ratio. Goal, if it's above 3, that's kind of worrisome and seems to be a marker for metabolic syndrome as well. And then finally, some additional tests. This is not come on your standard lipid panel, just in case you see this. Lp(a), this is a different one, once again, costs money and can be helpful to stratify risk further. There's not one consensus on what is quote unquote high or dangerous, but some people say, either 50 milligrams per deciliter or 100 nanomoles per liter are risk thresholds. We're still working on, we're learning a lot about Lp(a). It does tell us that people have a higher risk, but we don't have a lot of good treatments for yet. So we're trying to figure out the utility of it, but that's a general lipid profile, just kind of working through that there. And one thing I did want to mention was, there's a certain patient profile. So people have small particle or who are insulin resistant or have metabolic syndrome, they tend to have this thing. So this is what we're looking at here. I mentioned before, low HDL, usually never a good thing to have low HDL. In these patients, they also have high triglycerides. And as we mentioned before, those ratios are elevated. So total cholesterol HDL higher than 4, and triglycerides HDL greater than 3.8 or 4, 3.8 in women, 4 in men. Those are high. Sometimes they may have normal or unremarkable LDL, but that's something to consider. And that's why we care so much. And also, HDL being low seems to correlate with ApoB issues. So especially with insulin-resistant patients, what we'll see is this HDL being low, we'll see, triglycerides being high. If you get ApoB, you'll tend to see that elevated. So we're having lots of particles, but LDL may not be. And that's why it's important to monitor particle can be helpful in that situation. That's where particles are really helpful in those discordant people, right? Where, hey, numbers say from a strictly LDL perspective, not that bad, but then particles are bad. Obviously, if you look at the other parameters as well, there's no get out of jail free card, right? Like if you're LDL, you're like, oh, I'm at like 98, like no big deal, but your triglycerides are like 400 and your ratios are through the roof and everything's bad. Like that is not a metabolically healthy person. So you can't say that. But that person, if they just looked at their LDL, they might be like, oh, I'm good. And that's why we treat the whole person and not just numbers. And that's really important. I think it's also worth mentioning that we do not treat HDL necessarily. We always want to be treating the atherogenic particles. So what I mean by treating the HDL is there's no real good intervention or medication that will raise HDL that leads to significant cardiovascular benefit. There are ways to increase your HDL. Usually that's through exercise. And so I do want to hit a target of HDL. I'm trying to treat HDL in the setting of that, hey, I want that to get higher by exercising. That's what I want. But that doesn't seem to be the mainstay. If we just, in isolation, just elevate our HDL by medication, that doesn't seem to improve outcomes. And that's what I mean by that in terms of treatment. Usually it's aimed more towards lowering those ApoB particles or our LDL. That's what we're kind of thinking. But if you're doing the things to elevate your HDL, you're probably going to have lower triglycerides, better ratios, better ApoB, all those things as well. And so it's not just isolation. I don't want to be focused on HDL saying, hey, it's just HDL. It is important. I like it. I like having it high. I like seeing that. That's important. But it's kind of this whole picture, not just one thing, if that kind of makes sense. And so moving on as well, do want to talk about just variations of lab tests. This whole season kind of talked about, hey, there's lots of lab variability. And like all labs, there's definitely variability here. Sometimes what we'll see, just an article I saw looking at lab, so one person, same person getting the test, looking at different levels, they could have a 7% difference in their total cholesterol, a 12% difference in HDL, 27% change in triglycerides, and about 9% in LDL. And so if you get someone who, hey, my LDL was 105, and then you get it and it was 100 next time, is that a real signal, or is that pretty much exactly the same? That's just, once again, I just like throwing it out there to confuse everyone and to make us question everything that we do. Because I know before I learned all these things, I say, oh, like this is great, we're heading in the right direction. Now I don't know, but we can know directionally if we're heading in the right direction based on these numbers. But that's just to say that a single lab test doesn't tell everything, and a small decrease or increase may not mean anything of any significance, but just something to think about as well. And next, I did want to talk about how exercise affects the lipid panel. We've talked all about exercise for lipids in a previous podcast, but this is just kind of a review and we're talking the acute side as well. In the acute setting, there's probably not that big of a difference. It doesn't really do a whole ton. They've kind of looked at some studies where strenuous exercise may increase HDL acutely, also may increase or actually decrease LDL. Depends. Triglycerides seem to be relatively about the same. But that being said, because there can be some fluctuations, it's probably ideal to hold off 24 hours before getting a lab test. Chronically, though, you can see improvements, albeit they're kind of small in HDL, LDL, and triglycerides, but really not a lot. We're talking like 3 to 7 milligrams per deciliter, so not a ton. Probably not enough to really move the needle, meaning, hey, if you exercise, you may increase your HDL a little bit, you may decrease your LDL. That shouldn't be the only lever you're turning, right? So like very rarely is there a person who's like, oh, I don't work out and I work out and get enormous benefit from things. Usually that's associated with other things like weight loss, right? We know that weight loss can also greatly improve all those markers. And so a lot of times, like in and of itself, exercise does have a positive effect. I'm not saying it doesn't, but it's usually not enormous, because usually those things that really make a difference are associated with either dietary changes or kind of weight loss as well. And so putting it all together, the lipid panel can be helpful, but it can be made more helpful with ApoB or other tests if you want to. And you do not by any means have to get one. It's additional money. I don't think you have to do it, but it can be helpful. And then when we do get that lipid panel, we want to work through it systematically, right? So looking at our triglycerides first, making sure they're not elevated. Then we're looking at either our LDL-C, non-HDL, or the ApoB. Once again, those are kind of proxies for how many particles we got hanging out there. Looking to get those in a normal range. Then we look for HDL, not necessarily for a treatment goal, but just kind of give us information. And we can look at other things like the ratios. For me, the ratios, a lot of people will talk about, hey, the ratios are the most important thing. Everything else doesn't matter. Ignore LDL. This conversation, once again, I've talked about this ad nauseum multiple times and how I don't believe that we should just ignore LDL. And there's a certain set of people say, hey, if I'm metabolically healthy, don't care about my LDL. And that's fine. Once again, I'm not here to argue that or say you can't do that. For me, it's a risk factor. It does play a role in atherosclerosis, whether you believe it's the inflammation that's underlying whatever have you. I think it's reasonable to try to keep it in a reasonable level because I think you can do it in multiple ways. I don't think there's one you have to do this diet. If the only dietary intervention you have skyrockets your LDL, then that's a tough decision, right? You have to kind of talk about things and figure it out and figure out where your risk, tolerance sits. But overall, generally, I kind of go on the side of, hey, I'd like to keep that in control as well. And that's what I think about. And so those people sometimes say ratios are the most important, and ratios do seem to be important in that they can be predictive, but they just don't seem to be as predictive as things like ApoB specifically. And so if I had to pick between a ratio or an ApoB, I would for sure get an ApoB for sure. And then that's kind of my general gist on things. I hope this clears things up a little bit when you're looking at it. Can be helpful. At the end of the day, I just want to be, honest and say, hey, this is what we look at, and just kind of give this information to you so you can kind of decide what to do with it. But this does conclude the podcast. Thanks so much for stopping by. I really appreciate it. I hope you found it helpful. And if you did, it would mean the world to me if you gave a 5-star review on your podcast platform of choice, or if you share it with your friend who you think might enjoy it as well. And if you never want to miss a piece of content, please sign up for my mailing list, as I'll send out, the content when I release it. And I promise I'll never spam you because I hate spam just as much as you, if not more. But that's it for today. Thanks so much. Now get off your phone, go be active. Have a great rest of your day. We'll see you next time.